Hi guys, welcome to an on peri-operative medication review, which will hopefully be helpful for your surgical rotations. So the contents of today's session will be going over anticoagulants, things to stop before surgery, things to continue during surgery, and at the end we're going to talk a bit about diabetes medication. So, starting off with anticoagulation. So, this is a very complex topic, and I would always be guided by your senior, whether that's the surgeon doing the operation or the anaesthetist doing the operation. It really tends to be them making the decision about which anticoagulation a patient is to receive in the perioperative period. In general, a few things to consider are that aspirin tends to be continued before an operation if you're seeing someone that's potentially going to theatre tomorrow. Clopidogrel, however, tends to be stopped. A DOAC I'd always discuss with the anaesthetist. So different DOACs have different half-lives, so the length it takes for them to clear the system will be really different, and stopping them also depends on the risk of bleeding during the surgery, so what type of surgery they're having. So it will really be a case-by-case decision. Warfarin patients always require discussing with an anaesthetist. You may need to bridge a warfarin patient, so that's when you're providing another type of anticoagulation in the perioperative period that's not warfarin, with low molecular weight heparin or unfractionated heparin during the operation. And don't worry, your senior should definitely be able to show you how that's done, and whether someone's bridged is also usually a senior decision. So a helpful thing to think about when clerking in these surgical patients is to do an INR and a clotting screen, especially if they're on warfarin, and that will really make it easy for that senior to look at the INR and see what needs to be done. Always think, is bridging needed? Think about that patient and their specific VTE risks. Is it a big surgery? Are they likely to be immobile? Is it a cancer patient? That will guide you exactly what kind of medication to prescribe here. Things to stop before surgery in general, and this is where you might be a bit more involved in looking at a patient's drug chart that you're clerking in that might be going for emergency surgery. So I would always tend to stop non-steroidals and ACE inhibitors and ARBs because of the AKI risk. And also HRT and oral contraceptive pill are a bit more, you can continue them if it's minor surgery. Again, I'd discuss with an anaesthetist, but on the safe side, it could be that you stop them because of the VTE risk. Also, mostly herbal medications are stopped before operations. Again, you can just discuss with your local on-call anaesthetist if you're unsure about any of these. Things to continue. So it's really important to continue Parkinson's medications and anti-epileptic medications throughout surgery and not suddenly stop them. The progesterone-only pill tends to be safe to continue. And generally some cardiac medications such as alpha blockers, beta blockers, calcium antagonists, diuretics and statins tend to be continued. But again, review this on a case-by-case basis, looking at the patient, their renal function, their blood pressure, how they're doing, whether there's likely to be a lot of blood loss. Think about the physiology and why you might want to stop or hold these medications. And also gastroprotective measures like PPI and ranitidine, they're good to continue. Things to alter. So when a patient comes in and they're on steroids for some sort of condition and having a surgery, that counts as a stress for that patient. So you need to increase their steroids to a stress dose, which the patient can often tell you themselves. That they'll have an emergency card that tells you exactly how to change their steroid dose, because if you don't do this, you risk the patient going into an adrenal crisis. So this diagram here shows is a slight guide as to whether the patient is high risk for adrenal insufficiency. So think about why they're on those steroids. Is it just for COPD and inhaler, for example, or are they actually on a high dose of steroids? The endocrinology team would be a really helpful team to speak to if you're unsure about steroid dosing in the pre-operative period. Generally, as a rule of thumb, there will be your trust guidelines, but often the dose is doubled. But I would check this locally. For diabetes, always take into account the duration of fasting, the timing of the surgery, the patient's usual treatment, what have their previous HbA1cs been, which will guide what you do with their insulin and with all their diabetic medications. It can seem really confusing and it will take a while to get the hang of this. So in basically insulin dependent diabetes mellitus, and if you've got that and you're likely to miss more than one meal and you're having major surgery planned, they tend to get put on a sliding scale or variable rate insulin infusion. And it's good to be pragmatic about this, especially if you're working with, for example, a general surgery emergency CPOD list where it's likely that a patient might miss their slot and then get pushed to a later slot. In that sense, you'd be more likely to miss one meal, whereas for elective surgery, you can often plan that patient for the start of the day and reduce the need for needing a sliding scale. So I suspect that mostly foundation doctors would be in the setting of clerking someone overnight that's going for surgery the next morning. And if you had, for an example, an insulin-dependent type 1 diabetic, I think the safest thing would be to put them on a variable rate because you don't know whether they're going for theatre that first thing in the morning, and the patient needs to be nil by mouth. So hold hypoglycemic agents on the day of surgery, so such as sulfonylureas. That tends to be a rule for type 2 diabetes patients. And in the case of metformin, think about the risk of AKI in the surgery. Is there going to be a lot of blood loss? Or is there, for example, contrast used? And is the patient due to miss more than one meal? Then you can think of omitting metformin. And here on the right, I've just done a bit of an explanation on what a sliding scale is, or a variable rate insulin infusion, as this used to confuse me a lot. So it's different to when IV insulin is administered at a fixed rate. This is what we use in diabetic ketoacidosis. With a sliding scale, you've got an insulin infusion, but it's adjusted based on capillary blood glucose checks that the nurses will do every 1 to 2 hours. And then they modify the amount of insulin that's infused based on that glucose level. In order to do this, you're also giving continuous IV fluids, often with glucose, and those fluids will often need potassium in them as well, because remember that insulin changes your potassium levels. It's actually sometimes used in the treatment of hyperkalemia. Therefore, to offset that, you might need to give some potassium, and that depends on what the current potassium levels of the patient is. So there usually are very good local guidelines on sliding scales, and I would just follow exactly the protocol that's done in your trust, and that usually tells you exactly how much potassium to prescribe based on the patient's potassium levels. And when patients are on a sliding scale, they need their sodium potassium checked daily. So it will be confusing the first time you've done it, but the moment you've prescribed one sliding scale, you can tick that off and you'll be much more confident for the future. And that was it for perioperative medication review. As a general rule of thumb, this is just guidance, and I'd always ask for help from your seniors, be that the surgeon, the med reg, or the anaesthetist doing the operation, who'd be happy to help you. And often there are local trust policies to what exactly is stopped and started as well. So make sure to have a look at that as well. Thank you very much.